Hello, I'm Dr. David Kandzari, Chief of Interventional Cardiology at the Piedmont Heart Institute and Chief Scientific Officer for Piedmont Healthcare. And with me is my good friend and longstanding colleague, Dr. Vinod Thourani. Vinod is the Chair of Cardiovascular Surgery, the Marcus Chair of Cardiovascular Surgery for the Marcus Heart and Valve Center and Piedmont Healthcare. Vinod, thanks for being with me today.
Absolutely, David.
Amidst very challenging times with the COVID illness, Vinod and I are here today in a welcomed opportunity at Piedmont Atlanta Hospital to share with you an overview of the ACC 2020 scientific sessions with regard to key featured research and late-breaking clinical trials. First and foremost, however, both Vinod and I wish you, your loved ones, your families much safety and health during this time period. And like many other scheduled events and major cardiovascular meetings, for example, the ACC meeting this year, of course, was restructured into a virtual meeting with featured key research and late-breaking trials presented over the internet with discussion from leading experts. And Vinod and I have been part of many of these clinical trials. And so, Vinod, again, it's a great opportunity to have both of us here with a bit of social distancing.
That's right. We're keeping our 6 feet.
to review as best we can, in a short period of time, key studies that are of high impact to us in clinical practice, both here in the Piedmont healthcare system and elsewhere. And in particular, Vinod, I'll just start out with you, because you, as a very experienced cardiovascular surgeon, but somebody who has been one of the leaders, both in the U.S. and worldwide, in structural heart disease, what are the trials that are most important to you?
So, David, I think this is an interesting time, and also I agree with you that I want to hopefully have everybody who's watching this have safety within their own family and their other loved ones. So at ACC, as you know, that virtual aspect, there was 3 studies that really caught my eye that I thought were very important. The first was a partner 3 study. This was with a balloon expandable valve in low-risk patients. And so this is where, for those of you who don't know, about 80% of all aortic valve therapy patients who undergo some type of replacement are actually low-risk or surgical patients. So this is really the big piece of the pie. And so this was the first time that we've done a 2-year follow-up for those patients. ACC last year, we presented the 1-year data for that, and now this is the 2-year data for that, where all patients completed their 2-year follow-up, which was quite interesting. What we saw from year 1 to year 2 is that the composite endpoint was different between surgical and surgery and TAVR. What we saw in 1 year is that there was a superiority of TAVR. Yeah. So that really is the big thing that I got out of this. When you look at the individual components of the primary endpoint, you start to see that TAVR at between year 1 and year 2 starts to get closer to surgery. And I think that's an important aspect that we'll need to keep into our armamentarium as we think about what patients are going to have surgery in TAVR.
Vinod, just to highlight some of the specific elements of the endpoint that occurred over a time period between years 1 and 2, as I recall, there seemed to be at least a numerical excess of stroke in the TAVR cohort, right? Is that kind of a red herring, or is that a true signal of something of concern?
Not right now. It's not a major concern that I have. It's something that we have to continue to monitor those patients, and we're deep diving into the reasons for that. We did see a higher stroke rate from year 1 to year 2 in the TAVR patients, but when you look at the 2-year totality, there's no difference between the two. And so I think that there's a potential that we'll have to look at specifically. Is it thrombus? Is it not? And why are we seeing that? Is it atrial fibrillation? So there are a variety of things that we'll have to look into. The primary endpoint was still met, where TAVR did better than surgery. However, we have to look at the individual components. Like you mentioned, stroke is one of those that we have to look at.
And what about valve thrombosis related to, since you brought it up,
right,
that I think was similar between the groups, was it not?
It was. We did see a little bit higher valve thrombosis in the TAVR patients from year 1 to year 2. And what we're not finding any major clinical differences between those aspects of having thrombosis or not. So Raj Makkar has looked at the CT sub-study portion of it, which we're now sending off for publication. And that also did show that TAVR may have had more thrombus, but it didn't have any more clinical events for that. So really, we're still evolving in really what's going to be the therapy for that. And that kind of dives us into the next study, which is a popular TAVI study, which was done, and it randomized close to 300 patients where they actually looked at oral anticoagulation versus oral anticoagulation and clopidogrel. And what it did actually show is that there were a higher rate of bleeding with the clopidogrel group, but not really nearly as much, not a huge benefit for that. So really adding Plavix to oral anticoagulation doesn't make a ton of sense in transcatheter valve therapy. So we haven't answered our question really of how do we manage anticoagulation after transcatheter valve therapy. And that's something I think we're going to need to do over the next 2 to 3 years.
And when we transition to the interventional trials, this combination of antiplatelet therapy and oral anticoagulation, that'll come up in some of our studies that we'll discuss too.
Right, so it's quite interesting, and I think that's going to be the big bulk of what our therapy analysis really becomes over the next couple of years. The third study that we'll briefly talk about, which was with a self-expanding valve, the core valve, in bicuspid valve patients. So this was more of a registry. It was not a randomized trial as the previous two that I've spoken about. And the results were pretty good. There was in low-risk patients who had bicuspid valve type of architecture of the aortic valve, there was a very low mortality. In about 150 patients, there was only a 1% or so mortality, which is great results. So I think on the mortality end, we made great progress with that. The question is paravalvular regurgitation in these bicuspid valve patients, and I think that really is something we have to get our handle on how important that is. 40% of the patients had at least a mild paravalvular leak, and I think that's something we have to ask as a community between surgeons and cardiologists. Is that okay? Will that be enough for young patients with bicuspid valve patients? And the pacemaker rate was a little bit higher also than what we're used to, just above the 10% rate. So those are things that we'll have to look at and follow very carefully.
Given that the bicuspid population also is typically a younger population,
that's right.
All of these issues that you highlight probably have some significant longer-term implications. As we've seen in other TAVR trials, though, is there any evidence that some of the paravalvular leak is reduced over time or not?
No, generally not. Once you get to that year point, they haven't necessarily gone down. Sometimes we see the decreased PV leak rate from, let's say, intraprocedural to 30-day, but overall we haven't seen a huge detriment in the amount of paravalvular regurgitation from once we hit a year going forward. Okay. Usually we see those patients having problems further down the road. So those are the three big trials that caught my eye at virtual ACC and World Congress. Now it'd be fun to hear about the coronary stuff.
Certainly. So on the interventional side, I would say that there's probably three large categories of trials to talk about. One would be in the antiplatelet anticoagulation domain. The other would be with regard to long-term follow-up of complex coronary intervention, specifically left main disease, something you know a lot about as well. Right. And then third, I thought we would also talk about renal denervation, which was one of the most anticipated study results that was going to be presented at ACC. And maybe we could conclude with something that's common to all of us, the Ischemia Trial, and some sub-studies that came of that.
Right.
So very briefly, with regard to the collection of antiplatelet studies, we observed overall an increasing focus on this high bleeding risk patient population, but also the duration of dual antiplatelet therapy after complex coronary intervention. And specifically, we saw sub-studies from the Twilight trial. Recall that Twilight was a 9,000 patient study in which patients were randomized to 1 year after PCI of aspirin and ticagrelor, or 3 months of aspirin and ticagrelor, followed by discontinuing the aspirin and continuing ticagrelor alone. And the overall study showed no difference in ischemic events, and if but anything, significantly lower bleeding, favoring the shorter duration of dual antiplatelet therapy. This sub-study that was published by George Dangus simultaneously in the Journal of the American College of Cardiology showed that for complex lesions, so left main disease, bypass grafts, bifurcations, total occlusions, complex disease that we take care of in the interventional lab, that even still a shorter duration of dual antiplatelet therapy was not associated with any increased risk or hazard, so 3 months of aspirin and ticagrelor followed by ticagrelor alone. But in comparison, even in the complex patients, bleeding risks are still higher. Secondly, the Augustus Study was a trial of apixaban versus a vitamin K antagonist. So in a 2x2 factorial design, that trial also randomized patients to aspirin or placebo against the background of a P2Y12 inhibitor. This was in ACS and PCI patients. And that study similarly showed that for 1 month after PCI or presentation with an ACS, acute coronary syndrome, 1 month of triple therapy with an oral anticoagulant, Plavix, and low-dose aspirin probably reduced ischemic events and favored the benefit for 1 month, but thereafter increased bleeding complications. So 1 month of triple oral therapy is probably enough in patients with ACS and PCI. And the final one that we presented along with my colleague and co-principal investigator was the Onix 1 CLEAR trial. This was a study that fell against the background of a large multinational study, the Onix 1 randomized trial we published recently in the New England Journal of Medicine, which we showed with the Resolute drug-eluting stent that 1 month of dual antiplatelet therapy alone after PCI, independent of lesion complexity and high bleeding risk patients, was associated with favorable safety over long-term follow-up. So again, a collection of studies that highlight that probably bleeding risk rather than ischemic risk or lesion complexity probably should determine or dictate our decision-making about dual antiplatelet therapy long-term or short-term in these HBR or high bleeding risk patients.
And David, I think that's become more and more important, especially in patient populations that I see a bigger problem is atrial fibrillation. Did any of these really address atrial fibrillation and also PCI needs for PCI and that potential for triple therapy? How important is that for you as an interventional cardiologist?
So 2 of those studies, for example, would address that. One would be the Augustus Study, which involved apixaban versus a vitamin K antagonist, again suggesting that 1 month of triple antithrombotic therapy was good, and then stop and just go to the P2Y12 inhibitor, most commonly clopidogrel, plus the oral anticoagulant after that. Similarly, in the Onix 1 CLEAR study that we presented, we had 1,500 patients, both from Europe, Asia, and the United States, so a very broad representation. More than a third of those patients were receiving an oral anticoagulant as well, and again, 1 month of dual antiplatelet therapy.
I think that's important to make sure that at a month that triple therapy stops and follow those patients up, because if they don't and they continue for 2-3 months, we're going to see a lot of bleeding rehospitalizations.
And the implications of bleeding seem to be at the same risk as the implications of an ischemic event with regard to mortality. One other quick study just to reference in the realm of antiplatelet therapy was a study called Taylor PCI, which is interesting. It revisited genotyping for the cytochrome P allele, the loss of function star2 or 3 allele for impaired metabolism of clopidogrel. And interestingly, that study took patients who, by a genotyping method, were then randomized to either clopidogrel, if they did not have the loss of function allele, or ticagrelor. And that study didn't quite meet its endpoint, but it suggested that ticagrelor had, with a high statistical trend, superiority for reducing ischemic events. So whether we see that coming back into clinical practice remains to be seen. Beyond that, though, my second category, as I shared with you, was long-term follow-up of patients undergoing either left main PCI versus bypass surgery. This was not the Excel trial, but rather the...
We'll stay away from the controversies of the
We're going to come
trial.
to it, but the pre-combat study, which of course was very much underpowered for individual endpoints. This was a 600-patient study, but nevertheless, at 10-year follow-up as featured research, my colleague Dukwoo Park from Korea demonstrated that there was similar death, MI, and stroke between the 2 treatment strategies, but like with other studies, the need for repeat revascularization was 2 times higher in the PCI arm. What it is reassuring, though, is that against the background of Excel, Piedmont was the world's leading enrolling center for that study, there was a suggestion that perhaps there was significantly higher all-cause mortality, not cardiovascular, but all-cause mortality in the PCI arm. We didn't see that in pre-combat. Now at 10 years. We haven't seen that in the 10-year follow-up of the Syntax trial in the left main cohort as well. And so I think these are overall fairly reassuring findings against in the context of some recent controversy around the Excel trial.
Yeah, and I think it just talks a lot about the heart team. Right, when you have patients with left main disease, just like we have in the valve space, I think there is a lot, I know we do at Piedmont, there's a lot of heart team decision making that needs to be made.
Very much so.
And I think that's an important aspect that as I come out of the Excel and all the controversy, it just, to me, solidifies a need for a heart team to making the right decision for these patients.
And that's been perhaps my most memorable positive experience of the Excel trial is the collaboration we had between the interventionists and the surgeons here as well. As I mentioned, perhaps the most anticipated of studies, at least in the interventional domain, was related to renal denervation. And we presented and published simultaneously in The Lancet the Spiral Off Meds pivotal trial. Renal denervation in 3 sham-controlled feasibility or phase 2 studies has demonstrated significant and meaningful reductions in blood pressure, but in the context of previous studies like Simplicity HTN-3, where many perceived that this therapy was completely ineffective but safe, this next generation of studies have demonstrated more than proof of principle. And I think this is now an issue put to rest whatsoever, as the Spiral pivotal off-med study demonstrated absolute reductions of about 9 millimeters mercury systolic for the office blood pressure and about 4 to 5 millimeters reduction for the ambulatory blood pressure over 24 hours. We see this always-on effect of renal denervation, which is quite distinctive from medicines, where at every time period over 24 hours, there's a persistent, sustained reduction in the blood pressure with renal denervation. And equally important, it's a very safe procedure as well. So it's one next step towards, I think, making this more widely available as a regulatory pivotal trial to patients both in the United States and abroad. We're also performing a large complementary trial in an on-meds population where we really think this will be used, because we think that patients will have uncontrolled hypertension, not be off medicines, but have uncontrolled hypertension, and we would add this to achieve better control for them.
So maybe 2020, 2021 will be a higher penetrance then of renal denervation within the regular practicing cardiologists. Do you foresee that?
I think that over the next 1 to 2 years too, as we see this emergence of more data in the on-med setting, this will be a very hot topic time for renal denervation, as we see it having the potential to be introduced into clinical practice. And the other issue too will be what reductions we see in the on-meds population. We typically saw greater reductions in that population, and the higher the blood pressure, also the greater reductions as well. And so how that gets enveloped into clinical practice and with patient preference, realizing many patients aren't taking their medicines, will be important.
I think it'll be really important to see what the real world effects of this are as it takes into play, and it comes out of the trials where it's been very standardized and stuff. So I think that'll become very important to see how this is adopted, number one, and then number two, on meds, the real world experience. I think that'll be important.
You couldn't state it better. As probably a concluding point to this, there is already experience in about 3,000 patients in real world practice demonstrating safety and benefit in what's termed the Global Simplicity Registry, but you're absolutely right. We want to see even still further extension into a real-world clinical setting.
Absolutely.
So the final study, perhaps, Vinod, that you and I could discuss together, not presented per se as a late-breaking study at ACC, but presented last year at the AHA meeting, but published in 3 separate manuscripts simultaneously during ACC in the New England Journal of Medicine, was related to the Ischemia Trial. So recall, in the Ischemia Trial, 8,500 patients were approached or enrolled for the trial. Patients had to have moderate to severe ischemia on non-invasive testing. Interestingly, by CT angiography, which was performed in the majority of the patients, about 15% of them didn't have significant disease. Despite that, about 5% had significant left main disease. Those people were excluded, and so altogether we ended up with about 5,100 patients enrolled at multiple centers globally and randomized to either an invasive strategy, which could involve surgery or PCI, or medical therapy. And the study showed no overall difference at a median of 3.3 years, as I recall, in the outcome, a confusing one, of death, myocardial infarction, hospitalization for unstable angina, heart failure, and I think cardiac arrest, if I'm not mistaken, but no difference overall, no major difference in death or myocardial infarction. And in the chronic kidney disease population, again, with a GFR less than 30, no difference in death and MI, but a substantial benefit with regard to quality of life, patient self-reported quality of life. In fact, the number needed to treat was only 3. And so now we saw an interesting sub-study, however, presented as featured research at ACC, where we saw in the Ischemia Trial a numerical excess of events early on in the invasive arm, but then over longer term follow-up, the curves crossed, and there's an excess in the conservative arm. And it appears now, and further analysis that an invasive strategy was associated with a significant reduction in spontaneous myocardial infarction versus periprocedural myocardial infarction. And spontaneous myocardial infarction, rather than, depending on the definition, periprocedural MI, was the greatest predictor of both all-cause and cardiovascular death. So I don't know what your take is, but there may be some signal here of positivity even in these stable angina but moderate to severe ischemia patients with an invasive strategy.
Absolutely, and I don't think that we're conflicted because we see so many of the studies in this, and yes, this is what we do from surgery and an interventional point of view. But at the end of the day, quality of life is really what I'm shooting for. Obviously, we know that cardiac surgery is a sternotomy. It does cause more pain or decrease in quality of life for the first 30 days. But for patients who are coming to us who are looking for a longer term relief of angina and quality of life, I do believe that you have to start thinking about the PCIs and or the surgery to relieve their quality of life, get them back in the workforce.
Yeah.
If we leave, I understand it for an 85-year-old or a 90-year-old, maybe we do follow a more conservative pathway. But I think for patients who are working, who are active, who are looking for a better quality of life, I do think that you have to think very seriously about interventions, either direction, PCI or surgery. So the Ischemia Trial has, I think, enlightened us a little bit on how to manage these patients. But overall, I still believe that the quality of life, long-term quality of life for patients is probably going to come from an interventional-based therapy. And this is now panning out in the data as they really deep dive into it.
No, I agree with you. We want to help our patients live longer free of disabling events and have a better quality of life. And while in a lower risk population, we may not change survival per se, if we can reduce myocardial infarction and improve quality of life, to me that's a winning opportunity. I think the long-term follow-up of ischemia, if it can be achieved through the grant application, will be of great interest.
Critically important.
Vinod, thanks for taking your time with me on your work day here in the hospital and amidst these times as well to review the data from ACC 2020, and thank you for being with us as well. We'll end where we started, and amidst these challenging times, both Vinod and I wish you and your families greatest safety and health.
Be safe.